Hello everyone, it's my pleasure and a great honor to share with you this very important lecture about ascending aortic aneurysm, etiology, medical management, and when to intervene. Our agenda will include introduction, causes, medical management, indications for intervention, and finally, management in special population. Let's start with rapid introduction. Aneurysm is the second most frequent disease of the aorta after atherosclerosis. Patients with aortic aneurysm are at increased risk of cardiovascular events, mostly unrelated to the aneurysm, but mainly related to common risk factors such as smoking or hypertension, or common pathways such as inflammation, as well as increased risk of cardiovascular comorbidities at the time of aneurysm diagnosis. So, what is the definition of aneurysm? By definition, an aneurysm is a localized or diffuse dilatation of the artery with diameter at least 50% greater than the normal size of the artery. How to differentiate between dilated aorta and aortic aneurysm? We use this term dilated aorta if the aortic diameter is 4 cm or more. If the aortic diameter has reached 4.5 cm or more, we call it aortic aneurysm. So what about the different segments of the aortic tree? The aortic root starts from the aortic annulus to the level of sinotubular junction. From the sinotubular junction till just before the origin of innominate or brachiocephalic artery from the aortic arch, this segment is called the ascending aorta. Then the aortic arch, which start with innominate artery and end with left subclavian artery, then distal to the origin of left subclavian artery until the diaphragm. This is the descending aorta. After the diaphragm or below the level of the diaphragm, we call it abdominal aorta, which is subdivided into suprarenal segment and infrarenal segment, guided by the level of origin of renal arteries. And by the way, ascending aorta, aortic root, aortic arch, descending aorta, all these segments collectively called thoracic aorta. Now we will talk about causes of aortic aneurysm. What are the famous causes of aortic aneurysm? The first cause is heritable thoracic aortic disease, which is subdivided into syndromic and non-syndromic. Syndromic HTAD or heritable thoracic aortic disease include Marfan syndrome, Lewis-Dietz syndrome, vascular Ehlers-Danlos syndrome, while the non-syndromic HTAD include mutations in some genes like ACTA2 gene or BARC-G1 gene and other genes. And also it include familial thoracic aortic aneurysm without identified pathogenic variant in a known gene for HTAD. The third cause is congenital condition, such as bicuspid aortic valve, Turner syndrome, aortic coarctation, or complex congenital heart disease, such as tetralogy of Fallot, transposition of great vessels, and truncus arteriosus. The other causes of aortic aneurysm include also hypertension, atherosclerosis or degenerative, previous aortic dissection, inflammatory aortitis, which include giant cell arteritis, Takayasu arteritis, Behçet disease, and sarcoidosis. We have also infectious aortitis, which could be caused by bacterial, fungal, or syphilitic disease. And finally, previous traumatic aortic injury. So, to summarize the causes of aortic aneurysm, aneurysm of the aortic root and ascending aorta tend to have congenital or hereditary cause and present at younger age, while the aneurysm of the descending aorta tend to have an atherosclerotic cause and present at older age. Aneurysm of the aortic root and ascending thoracic aorta are also commonly associated with bicuspid aortic valve. Finally, many aneurysms of the root and ascending thoracic aorta are sporadic and idiopathic in origin. Now let's move to the medical management of aortic aneurysm. The medical management include 7 items. The first one is smoking cessation, physical activity and quality of life, blood pressure management, statins, antiplatelets, medical therapy in Marfan syndrome, and finally medical therapy in Lewis-Dietz syndrome. Let's start with smoking cessation. According to the American College of Cardiology guidelines for management of aortic aneurysm, which was released in 2022, in patients with thoracic aortic aneurysm who smoke cigarettes, smoking cessation efforts are recommended. What about the physical activity and the quality of life? Patients with significant aortic disease, education and guidance should be provided about avoiding the intense isometric exercise such as heavy weight lifting or activities require Valsalva maneuver. Also, for patients who have undergone surgery for aortic aneurysm or dissection, post-operative cardiac rehabilitation is recommended. In patients with thoracic or abdominal aortic aneurysm whose blood pressure is adequately controlled, it is reasonable to encourage 30 to 60 minutes of mild to moderate intensity aerobic exercise for at least 3 to 4 days per week. For patients with clinically significant aortic disease, it is reasonable to screen for anxiety, depression, and post-traumatic stress disorder when indicated. What about blood pressure management? In patients with thoracic aortic aneurysm and average systolic blood pressure of 130 mm mercury or more, diastolic blood pressure of 80 mm mercury or more, the use of antihypertensive medications is recommended to reduce risk of cardiovascular events. In patients with thoracic aortic aneurysm, regardless the cause and in absence of contraindication, Use of beta blocker should be considered to achieve the target blood pressure goal, and if the blood pressure is not controlled on beta blocker, we can add ARB, angiotensin receptor blocker, to achieve the target blood pressure goal. What is the role of statins? In patients with thoracic aortic aneurysm and imaging or clinical evidence of atherosclerosis, statin therapy at moderate or high intensity is reasonable. In patients with thoracic aortic aneurysm who have no evidence of atherosclerosis, then the use of statin therapy will be only class 2B, which means may be considered. In patients with aortic atherosclerotic disease and risk factors for confirmed coronary artery disease, it is also reasonable to prescribe moderate or high intensity statin. In patients with aortic atheroma of a thickness at least 4 mm or more, statin therapy may be reasonable. What is the role of antiplatelets? In patients with atherosclerotic thoracic aortic aneurysm and concomitant aortic atheroma or penetrating atherosclerotic ulcer, use of low-dose aspirin is reasonable unless contraindicated. In patients with aortic atherosclerotic disease and concomitant coronary artery disease, peripheral arterial disease, or both, it is recommended to prescribe antiplatelet therapy, anticoagulant, or both, guided by clinical setting. What about the medical therapy in Marfan syndrome? In patients with Marfan syndrome, treatment with either beta blocker or an ARB in maximally tolerated doses unless contraindicated is recommended to reduce the rate of aortic dilatation. In patients with Marfan syndrome, the use of both beta blocker and ARB in maximally tolerated doses is reasonable to reduce the rate of aortic dilatation. Then, medical therapy in Lewis-Dietz syndrome. In patients with Lewis-Dietz syndrome, treatment with beta blocker or an ARB or both in maximally tolerated doses is reasonable. Now let's move to the indications for intervention. The indications for interventions depend on the etiology of the aortic aneurysm. So, to define the management strategy, we have first to define the etiology or to identify the etiology of the aortic aneurysm. We will divide the etiology of the aortic aneurysm into 5 major categories. The first category is called sporadic aneurysm, and to call it sporadic aneurysm, it must fulfill the 3 criteria: no family history of aortopathy, no identified syndrome, no pathogenic genetic variant. The second group is non-syndromic HTAD, non-syndromic heritable thoracic aortic disease, without identified pathogenic variant. It is characterized by positive family history of aortopathy, but there is no identified syndrome and no pathogenic genetic variant. The third group is non-syndromic HTAD, but with an identified pathogenic variant. The fourth group is syndromic HTAD and finally bicuspid aortic. Let's start with the sporadic aneurysm. What are the indications for intervention? The first indication is symptoms attributable to the aneurysm, such as neck pain or chest pain due to compression on the surrounding structures by the enlarging aneurysm. The second indication is maximal diameter of the ascending aorta or aortic root of 5.5 centimeter or more. The third indication is rapid rate of growth. If the rate of growth is 0.3 centimeter or more per year in 2 consecutive years, or 0.5 centimeter or more in 1 year, surgery is indicated. The other indication for intervention is maximal aortic diameter of 5 centimeter if the surgery will be performed by experienced surgeon as a part of a multidisciplinary aortic team, and this was given a class 2A recommendation. The next indication is if the patient is scheduled for repair or replacement of tricuspid aortic valve and who have concomitant aneurysm of the ascending aorta with maximal diameter more than 4.5 centimeter, ascending aortic replacement is reasonable when the surgery is performed by experienced surgeon in a multidisciplinary aortic team. Indications for intervention in patients with ascending aortic aneurysm also include in patients undergoing repair or replacement of tricuspid aortic valve who have a concomitant aneurysm of the ascending aorta with maximal diameter of 5 cm, ascending aortic replacement is reasonable. In patients undergoing cardiac surgery for indication other than the aortic valve repair or replacement and have a concomitant aneurysm of the ascending aorta 5 cm or more, ascending aortic replacement may be considered. What about the indexed parameters? In patients with maximal cross-sectional aortic area divided by height ratio of 10 cm square per meter, surgery is reasonable when performed by experienced surgeon in a multidisciplinary aortic team. Also in patients with aortic size index 3 cm per meter square or more, or aortic height index 3.21 cm per meter, surgery may be considered when performed by experienced surgeon in a multidisciplinary aortic team. What about the second group, which is non-syndromic heritable thoracic aortic disease and there is no identified genetic cause? If the patient don't have high risk features for aortic dissection, the cutoff value for intervention is 5 cm or more. While if the patient has a high risk features for aortic dissection, the cutoff value will be lowered to 4.5 cm or more, or patients who are undergoing cardiac surgery for other indication, we will use the same cutoff value, which is 4.5 cm or more, provided that the surgery will be performed by experienced surgeon in a multidisciplinary aortic team. What are the risk factors for aortic dissection in patients with non-syndromic HTAD and no identified genetic causes? Family history of aortic dissection with an aortic diameter below 5 cm. Family history of unexplained sudden death below the age of 50. Rapid aortic growth 0.5 cm in 1 year or 0.3 centimeter per year in 2 consecutive years. What about the non-syndromic HTAD and with identified genetic causes? We have many indications according to the genetic variant, but the cutoff value could be only 4 centimeters if the genetic variant was BARC G1 and there is evidence of risk factor for aortic dissection. What about the Marfan syndrome? The cutoff value for intervention is 5 centimeter, and this cutoff value is lowered to 4.5 centimeter if there is a high risk feature for aortic dissection, provided that the surgery will be performed by experienced surgeon. We have also indexed parameter in patients with Marfan syndrome and the maximal cross-sectional aortic area to patient height ratio of 10 or more. Surgery to replace the aortic root and ascending aorta should be considered, provided that the surgery will be performed by experienced surgeon. In patients with Marfan syndrome and aortic diameter approaching the surgical threshold who are candidate for valve sparing root replacement and who have a very low surgical risk, surgery may be considered to replace the aortic root, provided that the surgery will be performed by experienced surgeon. The risk factors for aortic dissection in patients with Marfan syndrome include family history of aortic dissection, rapid aortic growth 0.3 cm or more per year, diffuse aortic root and ascending aortic dilatation, marked vertebral arterial tortuosity. What about Lewis-Dietz syndrome? The decision for intervention in patients with Lewis-Dietz syndrome depends on the genetic variants, presence or absence of high risk features, and aortic diameter. But we can intervene even at aortic diameter of as low as 4 cm if there is evidence of high risk criteria for aortic dissection and the genetic variant is either transforming growth factor beta R1 or transforming growth factor beta R2. Aortic surgery may be recommended at a smaller aortic diameter in Lewis-Dietz syndrome attributable to transforming growth factor beta R1 and beta R2 pathogenic variants when there are features that associated with a higher risk of aortic dissection, including certain specific pathogenic variants, like women with transforming growth factor beta R2 and small body size, severe extra aortic features such as cleft palate, hypertelorism, vivid uvula, marked arterial tortuosity, widened scars, and translucent skin. Family history of aortic dissection, especially at young age or relatively small aortic diameter. Aortic growth rate more than 0.3 cm per year. What about Turner syndrome? The decision for surgery or intervention in patients with Turner syndrome depends on indexed parameters. In patients with Turner syndrome who are 15 years or older with an aortic size index of 2.5 cm per meter square or more, plus risk factors for aortic dissection, surgery will be given class 2A. In absence of these risk factors, surgery will be given class 2. What are the risk factors for aortic dissection in patients with Turner syndrome? Aortic coarctation, aortic dilatation, bicuspid aortic valve, or high. What about the indications for intervention in patients with bicuspid aortic valve and concomitant ascending aortic aneurysm? The cutoff value is 5.5 centimeter or more. Also, we have indexed parameter, cross-sectional aortic root or ascending aortic area to height ratio of 10 or more, provided that the surgery will be performed by experienced surgeon in a multidisciplinary aortic. The other indications for interventions in patients with bicuspid aortic valve: diameter of the aortic root or ascending aorta between 5 cm to 5.4 cm plus additional risk factor for aortic dissection, provided that the surgery will be performed by experienced surgeon. Or patients with bicuspid aortic valve who are undergoing surgical aortic valve repair or replacement with concomitant aortic root diameter or ascending aorta more than 4.5 cm, provided that the surgery will be performed by experienced surgeon as well. In patients with bicuspid aortic valve and aortic root or ascending aorta between 5 and 5.4 cm without risk factor for aortic dissection, and the patient has low surgical risk, and the surgery will be done by experienced surgeon, surgery to replace the aortic root and ascending aorta may be considered. What are the risk factors for aortic dissection in patients with bicuspid aortic valve? Family history of aortic dissection, aortic growth rate 0.3 cm or more per year, aortic coarctation or root phenotype aortopathy. The last part in our lecture will be special population. The special population here is pregnancy. What are the indications for prophylactic aortic surgery before pregnancy in women with aortopathic conditions? The first indication is Marfan syndrome. The cutoff value for surgery is more than 4.5 centimeter. We can lower this cutoff value to only 4 cm if the patient with Marfan syndrome has risk factor for aortic dissection, including rapid aortic growth rate 0.3 cm per year or family history of aortic dissection. If the patient has Louis-Dietz syndrome with certain pathogenic variants in the transforming growth factor beta R1 and beta R2 or SMAD3, the cutoff value for intervention is 4 cm or more. In patients with Louis-Dietz syndrome but with genetic variation or genetic mutation in transforming growth factor beta 2 or beta 3, the cutoff value will be 4.5 cm or more. If the female patient has non-syndromic heritable thoracic aortic disease, the cutoff value is also 4.5 cm or more. Turner syndrome 2.5 cm per meter square or more. Bicuspid aortic valve 5 cm or more. Few important notes. Aortic dissection related to pregnancy has occurred at a small aortic diameter in women with ACTA2 or milk pathogenic variants. In patients with non-syndromic HTAD, prophylactic aortic surgery before pregnancy at smaller aortic diameters may be reasonable in these conditions, and other non-syndromic heritable thoracic aortic disease, and may be informed by molecular diagnosis, family history, and aortic growth rate. Similarly, in patients with bicuspid aortic valve, prophylactic aortic surgery may be considered at smaller aortic diameters depending on body size, aortic growth rate, and family. So, my final take home messages: at centers with multidisciplinary aortic teams and experienced surgeons, the threshold for surgical intervention for sporadic aortic root and ascending aortic aneurysm has been lowered from 5.5 cm to 5 cm in selected patients, and even lower in specific scenarios among patients with heritable thoracic aortic. In patients who are significantly smaller or taller than average, surgical thresholds may incorporate indexing of aortic root or ascending aortic diameter to either patient body surface area or height, or aortic cross-sectional area to patient height. Rapid aortic root growth or ascending aortic aneurysm growth. An indication for intervention is defined as 0.5 cm or more in 1 year, 0.3 cm or more per year in 2 consecutive years for those with sporadic aneurysms, and 0.3 cm or more in 1 year for those with heritable thoracic aortic disease or bicuspid aortic valve. The reference for this lecture is the 2022 ACC AHA Guidelines for Diagnosis and Management of Aortic Disease. Thank you so much.